Hello everybody, dear colleagues. Department of Endocrinology, Tbilisi State Medical University presents a part 3 of lecture Physiology and Pathology of the Hypothalamic Pituitary Complex. Lecture is given by the head of the Endocrinology Department of Tbilisi State Medical University, Professor David Metreveli. We should start talking with Cushing syndrome. Harvey Cushing, in 1912, described his patient with hypercorticism, but assumed it to be a polyglandular disorder. For almost 40 years, the etiology was disputed, though Bayer-Hurley had postulated that hypercorticism ultimately reflected adrenal hyperfunction, either primary or secondary. And nowadays, modern definition of Cushing syndrome. What is Cushing syndrome? It's an abnormal condition caused by excess levels of corticosteroids and especially cortisol in the body due either to hyperfunction of the adrenal gland, a form of adrenal adenoma or cancer, or hypersecretion of ACTH, adrenocorticotropic hormone, by the pituitary gland, or to prolonged use of corticosteroid medications such as prednisone, and that is characterized by a variety of signs and symptoms, including a full round face with the premature fatty deposition in the face, neck and upper back, truncal obesity, easy bruising, fatigue, muscle weakness, and hypertension. In this picture, we can see pituitary gland and its adrenal glands. And adrenal gland consists with the cortical part and medullary part. And in cortical part, there are three zones: glomerular zone, fascicular zone, and reticular zone. And hypothalamus pituitary adrenocortical axis. Few words about physiology. Hypothalamus secretes corticotropin-releasing hormone, CRH. Its CRH stimulates the pituitary gland, which secretes the adrenocorticotropic hormone. And adrenocorticotropic hormone stimulates the activity of adrenocortex and result the secretion of cortisol and another corticosteroid, cortisol. And this cortisol is a lipid-soluble hormone and not soluble in water. Because of this, it's necessary for circulation of cortisol in the blood. He's binding with globulin, special cortisol binding globulin. Only small fracture of cortisol in the blood is free part and is biologically active. The actions of cortisol. At first, we should know that free cortisol gets filtered in the kidneys and dumped into urine. And because of this, we can make a urine test for estimation of urine free cortisol level. So there is a circadian rate of secretion of cortisol, and cortisol levels peak at the morning and the levels drop in the evening. The biological effect, which in stress, cortisol secretion increased. It's increased gluconeogenesis, synthesis of new glucose molecules, increased proteolysis, breakdown of protein, and increased rate of lipolysis, breakdown of fat. Cortisol maintains blood pressure because the cortisol increased sensitivity of peripheral blood vessels to the catecholamines, epinephrine and norepinephrine, and result narrow blood vessel lumen. Cortisol dampens also inflammatory and immune response and reduce production and the release of inflammatory mediators. Cortisol acts on brain. It reflects any changes in brain. It may influence mood and memory. So levels of free cortisol also react and have negative feedback with pituitary hypothalamus, and this cortisol secretion, as I told previously, is increased with after stimulation because of stimulation of ACTH from pituitary. And now go back to the Cushing syndrome. Classification of Cushing syndrome. In classification of Cushing syndrome, we should look after a source of excess corticosteroids and cause. Initially, exogenous corticosteroids are results of therapy. Drug-induced Cushing syndrome. The commonest cause of Cushing syndrome is the use of exogenous corticosteroids to treat steroid-responsive disease, and such as the oral or inhalated corticosteroids, or topical corticosteroids, or injectable, for example, intraarticular corticosteroids. The second group is the endogenous hypercortisolism. It may be divided in ACTH dependent for one group, which is adrenocortical adenoma. So ACTH independent forms: adrenocortical adenoma, adrenocortical carcinoma, primary adrenal nodular hyperplasia. The last is very rare. Here we can see the picture with the tumor of adrenal gland. And another group is the endogenous. So form endogenous of the endogenous form. Another form is the ACTH dependent. So among endogenous hypercortisolism, the first was ACTH independent, and the last ACTH dependent. So the ACTH dependent hypercortisolism may be results of pituitary adenoma, so-called Cushing disease, which was described by the Cushing, and also ectopic ACTH syndrome. It's enough for rare. Among this endogenous, so pituitary adenoma is very important. So there are also other causes of hypercortisolism. And for example, in stress, physical or psychological stress increase the cortisol level. Depression or other psychiatric disorders also results hypercortisolism. Chronic alcoholism, severe obesity, poorly controlled diabetes mellitus, pregnancy, all of these conditions may result elevation of blood cortisol level and elevation of urine excretion of cortisol. Epidemiology of Cushing syndrome. Traditionally, the incidence of Cushing syndrome was reported as 2 to 4 per million per year. However, Cushing syndrome may be more common than previously thought. An unexpectedly high incidence of unrecognized Cushing syndrome has been demonstrated in high-risk populations. For example, 0.5 to 1% of hypertensive patients, or 2 to 3% of patients with poorly controlled diabetes mellitus, and 3 to 5% of obese hypertensive patients with type 2 diabetes. So, endogenous Cushing syndrome is more common in females. And what about clinical presentations? Many features of Cushing syndrome, such as weight gain, fatigue, depression, hirsutism, acne, and menstrual abnormalities, are also common in the general population, and the spectrum of clinical presentations is broad. Therefore, confirmation of the diagnosis may be delayed until 1 to 2 years after the onset of symptoms. A review of old photographs of the patient may be useful, as those with Cushing syndrome usually have progressive clinical features. Some features of Cushing syndrome that are common in the general population are more likely to be due to Cushing syndrome if the onset is at a younger age. These include type 2 diabetes mellitus, hypertension, osteoporosis, thin skin. Signs that are more discriminatory, also not unique to the Cushing syndrome, include easy breathing, proximal muscle weakness, facial plethora, reddish purple stain on the abdomen, breast, or things more than 1 centimeter in wide, weight gain with decreased growth velocity in children. Patients with pseudo-Cushing syndrome seldom have easy breathing of the skin or proximal muscle weakness. Other features seen in Cushing syndrome that may have other causes include reduced concentration, impaired memory, psychosis, reduced libido, unusual infections, poor skin healing, pigmentation, for example in ACTH-dependent cases, hypokalemia, usually in ACT-dependent ectopic cases. Which investigations we should give in case of suspicious for Cushing syndrome? As a road history should be taken to exclude exogenous glucocorticoid use causing iatrogenic Cushing syndrome before performing any biochemical test. Endogenous Cushing syndrome is rare, and conditions such as obesity, depression, diabetes, and hypertension are common. Thus, the risk of false positive results following biochemical testing is high. The rate of false positive cases may be reduced if tests are performed only in patients with a high pretest probability of having Cushing syndrome. For example, in patients with unusual features for their age, multiple and progressive signs and symptoms, especially those which best discriminate Cushing syndrome, adrenal incidentalomas, 2 to 20% prevalence of Cushing syndrome in such cases, and children with increased weight and reducing height per style. Which is initial high sensitivity tests which we should use? The following tests have a sensitivity of more than 90%, and any one of them may be used as the initial test depending on their suitability. Some tests are preferred over others in this certain situation. For example, 24-hour urinary free cortisol. 2 or 3 24-hour urinary free cortisol measurements should be made. Urinary creatinine and volume should also be measured to ensure adequate urine collection over 24 hours. But there is pitfalls. Urinary free cortisol measurement is not recommended in patients with renal failure, as levels may be falsely low due to reduced glomerular filtration. And a high fluid intake, more than 5 liters per day, may result in false positive results. And the next test is the overnight dexamethasone and low-dose dexamethasone suppression test. In the overnight test, 1 milligram dexamethasone is taken at midnight. If the serum cortisol measured next morning If the serum cortisol measured next morning between 8 and 9 a.m. is over 50 nanomole per liter, the test is considered abnormal. It means that is a failure of suppression with the dexamethasone. In the low-dose dexamethasone suppression test, we should use 0.5 milligram of dexamethasone, and which is taken at intervals of exactly 6 hours for 48 hours. For example, at 9 a.m., 3 p.m., 9 p.m., and 3 a.m. If serum cortisol measured at 9 a.m. on day 3, 48 hours after the first dose of dexamethasone, is over 50 nanomole per liter, a failure of suppression, the test is considered abnormal. So it indicates that this small dose, this low dose of dexamethasone don't result suppression of secretion of cortisol. But there is any pitfalls. Assays used for serum cortisol in dexamethasone suppression test measure total cortisol, free and bound to cortisol binding protein. Estrogens increase cortisol binding protein levels and therefore increase total cortisol level, but not free cortisol level. They should be stopped. These estrogen drugs should be stopped for 6 weeks prior to the test, as they may result in false positive results. Dexamethasone metabolism and clearance may be increased by some drugs. For example, phenterone, carbamazepine, rifampicin, and dexamethasone clearance is decreased in patients with renal or liver failure. Thus, simultaneous measurement of cortisol and dexamethasone, if it's available in these circumstances, is helpful. The next test is a late-night salivary cortisol measurement. In normal individuals, cortisol falls to very low levels at midnight. In Cushing syndrome, there is a loss of normal circadian rhythm. Saliva is collected either into a plastic tube by passive drawing or by the placing a cotton bridge in the mouth and shaving for 1 to 2 minutes. The sample should be collected at home in a stress-free environment. Pitfalls of this test. Circadian rhythm may also be blunted in the shift workers. Cigarette smoking should be avoided prior to the collection of the salivary cortisol, as tobacco contains an inhibitor of 11-beta hydroxysteroid dehydrogenase type 2, an enzyme that metabolizes cortisol. In patients with normal test results, Cushing syndrome is unlikely. However, if signs or symptoms progress, tests may be repeated in 6 months' time. If any one of the above tests is abnormal, another 1 or 2 of the above high-sensitivity tests should be performed. Mentioned above, some conditions such as depression, anxiety, obesity, alcoholism, and poorly controlled diabetes may be associated with hypercortisolism. These conditions may cause abnormal results of a urine-free cortisol measurement or the overnight dexamethasone suppression test. In these cases, the results should be treated with caution. Hypokalemia occurs more commonly in patients with ectopic HETH secretion, but it may also be seen in up to 10% of patients with Cushing disease. This is because these patients have higher level of cortisol, which saturates the cortisol metabolizing enzyme 11-beta hydroxysteroid dehydrogenase type 2. This results in excess cortisol acting as a mineralocorticoid in the kidney, causing potassium loss. How can we determine the cause? Patients with positive results on the initial screening test should have further tests to determine the causes of Cushing syndrome. Samples in plasma ACTH estimation should be called certificate immediately after venesection and flash frozen before storage, as ACTH is degraded quickly and falsely low results may be measured. ACTH levels of less than 5 picogram per milliliter are seen in patients with adrenal causes of Cushing syndrome. And ACTH levels, if more than 15 picogram per milliliter, can be attributed to the ACTH-dependent causes of Cushing syndrome. Plasma levels of between 5 to 15 picogram per milliliter should be repeated and interpreted within caution. High-dose dexamethasone suppression tests. The high-dose dexamethasone suppression test was previously used to differentiate between excess ACTH secretion from a pituitary adenoma and from an ectopic source. The high-dose dexamethasone suppression test is beside on the observation that hypercortisolemia caused by pituitary ACTH-secreting tumors is more sensitive to suppression by dexamethasone than hypercortisolemia caused by the ectopic ACTH-secreting tumor. The high-dose dexamethasone suppression test involves giving 2 mg of dexamethasone at 6-hourly intervals, and serum cortisol is measured before the first dexamethasone dose and 48 hours after the first dose. Cortisol is suppressed to less than 50% in about 80% of patients with Cushing disease, for example, and a sensitivity of around 80%. The test has a specificity of about 80%. It means that cortisol suppression is also seen in some patients with ectopic ACTH secretion. The high-dose dexamethasone suppression test has now been largely abandoned in centers where inferior petrosal sinus sampling is available. Imaging. Pituitary magnetic resonance imaging, MRI, scans should be performed if the biochemical tests have indicated the presence of an ACTH-secreting corticotrophic adenoma, Cushing disease. Initial biochemical confirmation is important, as pituitary incidentalomas may be seen in up to 10% of normal people, and 40% of corticotrophic adenomas may be missed on MRI. Corticotrophic adenomas may be seen as hypointense lesions on pituitary MRI that do not enhance with gadolinium. A low plasma ACTH concentration, less than 5 picogram per milliliter or less than 1.1 picomole per liter, should be followed by thin section computed tomography or MRI imaging of the adrenal glands, because dramatic suppression of ACTH usually is a result of adrenal gland cancer or adrenal gland adenoma. Those with a suspected ectopic source of ACTH should have further imaging, irradio-labeled octiotroid scan and MRI CT imaging, to look for ectopic ACTH-secreting tumors. High-resolution chest CT may identify the most common sites of ectopic ACTH secretion, for example, small cell lung cancer and bronchial carcinoid tumors. Radio-labeled octreotide CRAN are also used to detect carcinoid tumors as they express somatostatin receptors. Inferior petrous sinus sampling. This is the most reliable test for differentiating pituitary and non-pituitary source of ACTH. The inferior petrosal sinus receives venous draining from the cavernous sinus, which in turn receives blood from the pituitary gland and drain into the sigmoid sinus. Femoral catheters can be advanced bilaterally up to the internal jugular vein, sigmoid sinus, and finally into the inferior petrosal sinus to collect central blood. Blood is also collected from a peripheral vein. Patients with Cushing's disease show a basal central to peripheral ACTH ratio of more than 2.1, and this central to peripheral ACTH gradient became over 3 to 1 in case after CRH administration. And treatment of Cushing's syndrome. The treatment of Cushing's syndrome due to exogenous glucocorticoid therapy is to reduce the glucocorticoid dose and discontinuation if it's possible. This should be done gradually, as most patients will have developed hypothalamic pituitary adrenal suppression and deficiency following chronic glucocorticoid treatment. In case of ACTH-secreting pituitary adenomas, Cushing's disease, the treatment of choice for Cushing's disease is transsphenoidal surgery by an experienced neurosurgeon. If a clearly circumscribed microadenoma is identified by the neurosurgeon, transsphenoidal microadenomectomy is the treatment of choice. If no clearly circumscribed microadenoma is identified and future fertility is not an issue, subtotal, about 85 to 90%, anterior pituitary resection may be performed. If no clearly circumscribed microadenoma is identified by the neurosurgeon and future fertility is an important concern, radiotherapy may be used. Patients with post-transsphenoidal surgery cortisol level of less than 15 nanomole per liter are more likely to have prolonged remission. And patients with evidence of remission when cortisol level is less than 15 nanomole per liter in the blood, following surgery should have hydrocortisone replacement. Medical treatment with adrenal enzyme inhibitors, ketoconazole and metrapol, may be given before surgery to control hypercortisolism and stabilize the patient. The dose is titrated to achieve a mean serum cortisol of 150 to 300 nanomole per liter. Metrapol inhibits 11 beta hydroxylase and blocks the final step in cortisol biosynthesis. It can exacerbate hirsutism due to increased adrenal androgen production. Hypertension can also occur as a result of increased production of deoxycorticosterone. Metrapol may be started at a dose of 250 mg twice a day and may be increased every 3 days up to 1 gram 4 times a day. Ketoconazole. Ketoconazole inhibits the first step in cortisol biosynthesis, side chain cleavage, and to a lesser extent, the conversion of 11-deoxycortisol to cortisol. It also inhibits ACTH secretion by the impairing corticotrophin adenylate cyclase activation. Ketoconazole may be started at a dose of 200 mg twice a day and is increased at 2 to 3 weekly intervals. Doses higher than 400 mg 3 times a day are seldom effective. Liver function tests should be monitored weekly initially, as ketoconazole can result in hepatitis. Other side effects of ketoconazole include headache, sedation, nausea, vomiting, gynecomastia, impotence, and decreased libido due to inhibition of testosterone production. Hypertension and diabetes mellitus should be treated as normal. Patients with marked bone loss should receive oral biphosphonate therapy, calcium and vitamin D supplementation. Radiotherapy may be used in those who are not cured and have persistent hypercortisolemia after transphenoidal resection of the tumor. Pituitary irradiation is as likely to cure children as the surgery and may therefore be considered as the initial therapy in children. Stereotactic radiotherapy provides less irradiation to the surrounding tissue. Pituitary irradiation using a linear accelerator may be correct hypercortisolism at about 45% of adults and about 85% of children. The maximal benefits do not occur for at least 9 to 12 months, and occasionally as long as 2 years into adults. Children usually respond within 3 months. During this time, adrenal enzyme inhibitors should be used to control the hypercortisolism. The major side effect of radiotherapy is progressive hypopituitarism. Nearly all patients will have growth hormone deficiency 10 years post-radiotherapy. And luteinizing hormone and follicle-stimulating hormone deficiency may be seen in up to 15%. In refractory cases where surgery and radiotherapy fail to normalize cortisol secretion, surgical bilateral total adrenalectomy or medical adrenalectomy with match time with lifelong glucocorticoid and mineralocorticoid replacement is the final definitive cure. Monitoring of mitotan levels and dose adjustment is frequently advocated. In patients who cannot be treated with adrenalectomy, adrenal enzyme inhibitors may be used long-term to ameliorate the hypercortisolism. Bilateral adrenalectomy may rather be complicated by the development of so-called Nelson syndrome. This was originally characterized by a locally aggressive pituitary tumor causing skin pigmentation due to excessive ACTH secretion. In this picture, we can see the case with pituitary adenoma, ACTH produced adenoma. It results in hyperfunctioning, bilateral hyperfunction of adrenal glands and hyperproduction of cortisol. This cortisol results, in one hand, the manifestations of Cushing syndrome, but in another hand, this feedback action of this cortisol to the ACTH producing adenoma result the inhibition of secreting of ACTH, because the secretion of ACTH partially is react on the inhibition action of ACTH. After bilateral adrenalectomy, the inhibiting action of cortisol, of course, decreased because patient takes only low doses cortisol, glucocorticoids, enough for compensation of glucocorticoid deficiency, but these doses are not enough to suppress the activity of pituitary adenoma. Because of this, after bilateral adrenalectomy, the adenoma of pituitary start aggressive growth and producing a lot of ACTH. Because of this, develop the clinical picture clinical presentations of so-called Nelson syndrome with growth and mass effect of this pituitary adenoma and skin pigmentation. But nowadays, with the advent of pituitary imaging with CT and MRI, corticotroph tumor progression can be detected very early, and therefore Nelson syndrome is rarely seen. The corticotroph adenoma may require surgery and radiotherapy. And pituitary radiotherapy at the time of the adrenalectomy is effective in preventing Nelson syndrome. In case of ectopic ACTH secreting tumor, in patients with ACTH secreting ectopic tumors, complete excision often results in remission. However, in patients who are not cured after surgical resection of the tumor, adrenal enzyme inhibitors may be used to control hypercortisolism. In case of adrenal tumors, in patients with an isolated cortisol-secreting adenoma, unilateral adrenalectomy had a good prognosis. In patients with adrenocortical carcinoma, mitotan is used as an adjuvant therapy following surgery. Adrenal enzyme inhibitors may be used for when surgery is contraindicated or if the tumor is metastatic or occult. Prognosis. In the past time, Cushing's disease had a 5-year survival rate of 50% when not treated. However, with modern treatments, the standard mortality ratio following normalization of cortisol is similar to that of an age-matched population. In patients with persistent hypercortisolism, after treatment, the standard mortality ratio may be increased to 4 to 5 times that of general population. Most deaths are due to cardiovascular, thromboembolic, or hypertensive complications, or bacterial fungal infections. The initial remission rate with an experienced neurosurgeon is about 70 to 80%. However, permanent cure rate is about 60 to 70% due to late recurrence. The symptoms and signs of patients with Cushing's syndrome gradually resolve in their year following surgery. Impaired glucose tolerance, hypertension, and osteoporosis improve but may not disappear. Impaired health-related quality of life resolves partially but not completely after transsphenoidal surgery. It may remain below that of age and gender matched subjects for up to 15 years. Depression usually persists for many years following successful treatment. In children, bone density and growth rate both increase after treatment, but neither returns to normal. Patients with ectopic ACTH secretion or an adrenocortical carcinoma may have a poor prognosis associated with the underlying tumor. The prognosis for adrenocortical carcinomas is poor. They almost invariably recurrent and usually do not respond to irradiation or chemotherapy. Follow-up and monitoring. Patients should be followed up clinically for recurrence of features of Cushing syndrome, and dexamethasone suppression test should be performed when recurrence is clinically suspected. In patients in whom remission is achieved with surgery and who are taking hydrocortisone replacement, in insulin-tolerant tests should be done 1 to 2 years after surgery to look for the recovery of normal corticotropic function. And what about rare cases of ACTH-independent Cushing syndrome? For example, micronodular adrenal hyperplasia. Micronodular adrenal hyperplasia, also known as primary pigmented nodular adrenocortical disease, is characterized by the multiple small pigmented autosomously functioning adrenocortical nodules. It may be sporadic or familial, isolated, or as part of Carney's complex. Carney's complex is an autosomal dominantly inherited syndrome characterized by the spotty skin pigmentation, endocrine tumors, and non-endocrine tumors also, the myxomas of the skin, heart, breast, and other sites. And there are 3 responsible genes have so far been identified. Another cause of ACTH-independent Cushing syndrome is the so-called macronodular adrenal hyperplasia. Macronodular adrenal hyperplasia is characterized by the adrenal glands that contain multiple non-pigmented nodules larger than 5 mm in dimension. An ectopic adrenal expression of some G protein-coupled receptors or an increased expression activity of some eutiopic receptors may mediate the increase of cortisol secretion. The patients have increased serum and urinary cortisol and undetectable plasma ACTH in the basal state and after administration of CRH. Cortisol production is suppressed minimally, if at all, by high-dose dexamethasone. Cushing syndrome associated with McCune-Albright syndrome is a rare variant of ACTH-independent macronodular adrenal hyperplasia. McCune-Albright syndrome is a sporadic disease caused by the activation mutations of the gene coding for the alpha subunit of stimulatory G protein, which results in constitutive activation of the cyclic AMF pathway in the nodules and excess cortisol secretion. McCune-Albright syndrome is characterized by the caveolate spots, polycytic fibrous dysplasia, precocious puberty, and other endocrine disorders. Surgical bilateral adrenalectomy is used in patients with micronodular adrenal hyperplasia and most patients with macronodular adrenal hyperplasia. So, key points of this part of lecture. Cushing syndrome comprises a collection of signs and symptoms caused by a chronic inappropriate elevation of free circulating cortisol. Cushing syndrome may be caused by excess exogenous glucocorticoids, an ACTH-secreting pituitary adenoma, an ectopic ACTH-secreting tumor, and an adrenal adenoma or an adrenal carcinoma. Biochemical tests should only be performed in patients with a high pre-test probability of having Cushing syndrome. For example, in patients with unusual features for their age or multiple and progressive features that best discriminate Cushing syndrome. Initial high-sensitivity tests for Cushing syndrome include 24-hour urine-free cortisol measurement, an overnight dexamethasone suppression test, low-dose dexamethasone suppression test, and a late-night salivary cortisol measurement. Investigations to determine the underlying causes of Cushing syndrome include plasma ACTH, pituitary or adrenal imaging, depending on the plasma ACTH result, and inferior petrosal sinus sampling. The treatment of choice for Cushing's disease is a transsphenoidal surgery by an experienced neurosurgeon. The treatment of Cushing syndrome due to an adrenal adenoma is unilateral adrenalectomy. And the next part of our lecture is the clinically non-functioning pituitary tumor. Usually, clinically non-functioning pituitary tumor develops from the gonadotroph cells. It's a gonadotroph adenoma. Here in this picture we can see the big gonadotroph adenoma, which results in enlargement of sella turcica and also results the compression of surrounded tissue with manifestation of mass effect. And in many cases, this non-functioning adenoma may result the hypopituitarism because of compression of pituitary cells. And of course, this compression of optic head by clinical non-functioning pituitary macroadenoma may result the restriction of visual field. In this MRI, we can see supracellular extension of clinical non-functioning pituitary macroadenoma. Physiology and disorders of the posterior pituitary. Posterior pituitary is the place of storage of oxytocin and vasopressin, which are produced by the hypothalamus in paraventricular nucleus and supraoptic nucleus. This oxytocin and vasopressin then come down to the posterior pituitary and then is absorbed in the bloodstream. For the action of these hormones, for example, prolactin stimulates milk production in the endocrinologically prepared breast, and oxytocin causes milk expulsion. Oxytocin causes uterine contraction also. Vasopressin or antidiuretic hormone. They stimulate antidiuretic hormone secretion, maybe increased body fluid osmolality, decreased blood volume, decreased blood pressure, also angiotensin II, pain, stress, nausea and vomiting. And inhibit antidiuretic hormone secretion. The decreased body fluid osmolality, increased blood volume, increased blood pressure, atrial natriuretic peptide, and ethanol. Cells in the paraventricular and supraoptic nuclei receive input from osmoreceptors. They monitor change in body fluid osmolality, and peripheral baroreceptors monitor changes in the blood pressure and volume, and higher neural centers. Antidiuretic hormone descends nerve fibers and is picked up by capillaries of neurohypophyse. Antidiuretic hormone makes cortical collecting duct permeable to the water and thus permits it to be reabsorbed along with the actively reabsorbed salt. Antidiuretic hormone makes medullary collecting of duct permeable to water, permitting its reabsorption due to high osmolality of renal medulla. Approximately 180 liters of fluid filtered from blood plasma by glomerulus in 24 hours. And 90% of filtrated water reabsorbed in proximal tubule and Henle loop due to reabsorption of salt, leaving 15 to 20 liters a day. 14 to 16 liters reabsorbed daily under influence of antidiuretic hormone, resulting in 1 to 2 liters of urine in 24 hours. The deficiency of antidiuretic hormones may result central diabetes insipidus. The etiology of central diabetes insipidus may be trauma, skull fracture, hemorrhage, or after a neurosurgeon operation. Also, the deficiency of antidiuretic hormone may result tumor, craniopharyngioma, germinoma, or metastatic disease from lung, kidney, lymphoma, and so on. Also, infertility disorders, and for example, in case of sarcoidosis. In pregnancy, the degradation of antidiuretic hormone may increase, and it will result in the manifestation of so-called gestational diabetes insipidus. And after delivery, this condition improves, and the diabetes insipidus symptoms disappeared. Maybe developed the so-called diabetes insipidus, genetic diabetes insipidus, or for example, in Wolfram syndrome. There are cases of nephrogenic diabetes insipidus, failure to respond to ADH. So, the renal tubules are resistant to the ADH action. The treatment of central diabetes insipidus. Desmopressin is a synthetic modification of ADH or arginine vasopressin with a prolonged antidiuretic effect and no vasopressin activity. So, intranasal administration may be used in treatment of diabetes insipidus in initial dose of 5 micrograms is usually given at bedtime to control nocturia. The dose can be titrated up according to nighttime and daytime symptoms to a maintained dose of about 10 to 20 micrograms once or twice daily. Some adrenal endocrinologists recommended starting with the intranasal preparation to ensure that the patient understands what a good antidiuretic response is. The therapy can then be changed to tablets. In case of oral administration, only about 5% is absorbed from the gut. I mean the drug of antidiuretic hormone. The initial dose is 100 micrograms at bedtime and can then be titrated up to 100 to 400 micrograms 3 times a day according to symptoms. The absorption of desmopressin may be decreased by up to 50% when taken with meal. In case of subcutaneous administration, it's occasionally used. The usual dose is 1 microgram twice a day. Desmopressin is safe during pregnancy for both mother and fetus. Plasma sodium and osmolality and clinical response should be monitored And the desmopressin dose should be modified if necessary to ensure that patients are not becoming hyponatremic due to water intoxication. Physicians should be aware of interaction of desmopressin with other drugs, for example, carbamazepine, indapamide, that may increase its action. Treatment of nephrogenic diabetes insipidus. The underlying cause, for example, hypokalemia or hypercalcemia, should be treated if possible and the causative drug stopped. Treatment includes a low-sodium diet, thiazides, and non-steroidal anti-inflammatory drugs. Thiazides acts by inducing mild volume depletion, resulting in increased proximal tubular sodium and water reabsorption. This leads to the decreased water delivery to the collecting tubules, where antidiuretic hormone normally acts, and reduced urine output. Non-steroidal anti-inflammatory drugs inhibit renal prostaglandin synthesis and augmented antidiuretic hormone action. In patients who cannot be treated with non-steroidal anti-inflammatory drugs or who have persistent symptomatic polyuria after the addition of this drug, a trial of desmopressin may be given. And treatment of primary polydipsia. In case of primary polydipsia, the underlying psychiatric disorders should be treated. So, key points of this part of lecture. Diabetes insipidus is characterized by the hypotonic polyuria, a urine output of more than 3 liters per day with osmolality less than 300 milliosmol per kilogram. Diabetes insipidus may be central due to a deficiency of antidiuretic hormone produced in the posterior pituitary, or nephrogenic due to renal resistance to the action of antidiuretic hormone, or dipsogenic, also known as a primary polydipsia, due to excessive drinking. In all patients persisting with polyuria, glucose-induced osmotic diuretics should be excluded first. A water deprivation test is used to differentiate between central cranial diabetes insipidus and nephrogenic diabetes insipidus and primary polydipsia. In patients with central diabetes insipidus, the hypothalamic pituitary anatomy should be assessed with an MRI scan. Patients with central diabetes insipidus are treated with desmopressin. Plasma sodium and osmolality and clinical response should be monitored. The next part is a talk about tumor metastatic to the pituitary. Metastasis to the pituitary gland is a rare cause of an intracellular mass discovered during the life. But in autopsy, in patients with cancer, pituitary metastases are found in about 3.5% of patients. It may be metastasis from lung, from breast, from kidney, from rectum or sigmoid colon, or from melanoma. So, thank you for attention.